Hi, my name is Diana Berendt. I'm the founder of Survivor Corps, and welcome to the Survivor Corps webinar series. We know that you can't always get to the experts, so Survivor Corps is here to bring the experts to you. Today, our esteemed guest, Dr. Fauci, needs no introduction. Dr. Fauci, thank you for being a beacon in this storm, and thank you for being with us today. Thank you also to Deaf in Government for supplying interpretation services. Thank you. Now, let's get to work. So we all know about Dr. Fauci's background. We're a little bit newer on the block, only having existed since March. So let me just tell you shortly, I started Survivor Corps while I was in isolation with COVID in March, with the mission to mobilize an army of survivors to donate their plasma and support science in every way possible by participating in every trial or study for which we qualify. We've also become a patient advocacy group when we found that so many of us were not recovering. So with that background, Dr. Fauci, we just hit 9 million documented infections, and the CDC has said that 1 in 3 are not recovering in time. You've mentioned some of the ongoing symptoms people are experiencing, including fatigue, brain fog, etc. But we're also seeing people in their 20s and 30s having heart attacks and strokes after COVID. We're seeing COVID onset diabetes, COVID onset lupus, and other autoimmune disorders. Brain damage, really debilitating stuff happening to people at the prime of their lives with no pre-existing conditions. This has to be more than your average post-viral syndrome, no? Based on your early work at the NIH on the vascular elements of cancer patients and your leadership through the AIDS crisis, what do you make of this virus that is wreaking havoc on every organ in the system?
Well, I think what you have just expressed is important because it really is now making it quite clear that we do not know as much about this virus that we have to know, particularly that the symptoms that you're talking about are real. These are not imaginary. I mean, sometimes when you have post-viral syndrome, one of the things, because they are so elusive, that people tend to think that, well, maybe they're imaginary and they're not feeling things. Well, fatigue is sort of a vague thing. Muscle aches a little bit vague thing. But when people start having things like really bad shortness of breath, dysautonomia, difficulty in temperature control, really serious lack of concentration and ability to focus, those are the things that fall under their category of somewhat nondescript, but really real. We believe they're real. And we are starting now support of studies, both here at the NIH, as well as funding our grantees and our contractors to be able to study this over a long period. But you mentioned something else that's also troubling to me, and it's less of the non-specific things than are, for example, there was a study that was published recently in JAMA Cardiology, which showed that people who had variable degrees of involvement, from modest to severe to hospitalized individuals, who after they recovered virologically, they did MRI scans of their heart, because we know that well beyond just acute respiratory distress syndrome that advanced people have, some people have serious impairment of their heart, as well as of their kidneys, as well as of their neurological system. So the question is there subtle effects that people have after they appear to recover from the virological aspects that we need to pay attention to? And the answer is yes, because they found that a proportion of people had inflammatory manifestations in their heart, even after they felt like they were recovering. So the question that you brought up, that's a valid question. What's going to happen 6 months or a year or so from now? Will there be or not? We don't know. And we need to admit that we don't know. Will there be an increased incidence of arrhythmias, of cardiomyopathies, of heart attacks in younger people? And that's the reason why we're starting a series of large studies to see if we can figure that out. And having figured it out, is there any way we can intervene to prevent those after effects from happening?
Well, that brings me right to my next question. You led right into it. And I would also add that it is really attacking every organ system. I was just recently diagnosed with COVID onset glaucoma. And we are seeing quite a lot of ocular issues, just to name a particular organ, but I could probably name any at this point. With this, we could be looking at the largest group of disabled Americans, many of them young in history, including wartime. I mean, that is sobering. We are investing heavily in vaccines and to a lesser extent therapeutics for hospitalized patients. Where is the Operation Warp Speed for a therapeutic for long COVID? And shouldn't we be creating a standard of care for newly infected patients that could stave off the worst effects of this virus? Most people aren't hospitalized with COVID. I had the Tylenol and Gatorade variety. I like to say I spent 18 days in isolation and recovered at home. I never saw a doctor. Um, so most people are not hospitalized. They're not under any medical care, let alone eligible for any therapeutics. Doesn't it seem like we're leaving the vast majority of COVID patients out in the cold?
No, I don't think so. And I think before one can make any statement as to whether or not we're going to have a large cohort of, quote, disabled people, I'd be careful about that. And the reason is, once you start saying that, people will think you're exaggerating. So what I tend to do is collect data and let the data talk. And I believe, I mean, right now we have a study right here in where I'm sitting right now on this campus at the NIH of looking at large numbers of people just like yourself, not necessarily people who've got hospitalized. And we are going to have a workshop in December to bring experts from every single discipline in to get their input into the kinds of things that you're talking about. The first thing you need to do is establish what the scope and the extent is so that you do things like criteria of what kinds of your class 1, class 2, class 3. Those things are all in the making right now. So they're going to happen.
So how can we, as a patient-led group, a group of, let's call us citizen scientists, who are working with real scientists, work with the government, like agencies like the NIH, to get research and studies started, as more research and more studies going as soon as possible, so that we don't fall into the pitfalls that have stymied other groups. If you were the leader of this advocacy group, what would be the bullet points of your manifesto? We need long-term COVID care centers, and we need access to medical care, not based on insurance, employment, or a positive PCR test, because there were so many people who were unable to get those tests back in the spring, and many of them were faulty at the time. What else should be on our manifesto? What if you were the leader of this group?
Well, I would encourage, as they come out, they're not here yet, but they're rapidly going to be coming online. I would encourage you to have your constituents volunteer for as many of the clinical trials and studies that are going to be done to be able to determine the scope, the pathogenesis, and the ultimate treatment. So when you hear about studies in medical centers where you might live, because the NIH funds medical centers throughout the entire country, as well as other parts of the world, is to volunteer for those studies. The only way we're going to learn the real facts, and when you know the facts, then you can intervene, is by having clinical studies, cohort studies, studies that look at everything from imaging studies to metabolic studies to find out what's going on. So I would be loudly calling for people to volunteer for these studies.
So in fact, we have been doing exactly that since I started Survivor Corps in March. That is a huge part of our mission. And if you go to survivorcorps.com, it is a one-stop shop on how you can give back. I have engaged in every study for which I have qualified. I continue to do so. I've given blood for T-cell research, for vaccine research. I've donated my plasma 8 times. I could go on, and I encourage everyone else to do the same. And perhaps, Dr. Fauci, we could work more closely with the NIH so that we can broadcast those opportunities and work more in coordination.
Well, I think it would be very beneficial to work closely with the NIH, because once we get clinical investigators funded to do studies, they're going to be looking for people who would be in the studies. So if we could make the connection, which it's
We have
easy
the
to
people.
do, yeah, between your people and the NIH investigators, it would make the initiation and implementation of those clinical trials much, much easier and much more efficient.
Well, we are here for you. We have 115,000 members of Survivor Corps right now. And unfortunately, the numbers are growing exponentially. I'm glad that they're finding us, but it's unfortunate that so many people are having to. But we will work with you and we will supply all of the people who you need. And we are doing our own studies. We have a longitudinal study that we're doing at Columbia, tracking people both serologically and symptomatically. That's already started. It's called Recovery Corps. We're doing our own research with the Indiana University School of Medicine. We just closed out a 4,000 person IRB approved study looking at symptom sequela in mostly non-hospitalized patients. We would love to be able to work with you so that we can share our data and so it can be used by as many scientists and clinicians as possible. So I have a sort of a broader question here. So to paraphrase T.S. Eliot, the naming of a disease is a delicate matter. It's hard to be taken seriously to get a billing code, et cetera, without a name. You named AIDS. Can we agree on an official name for this? The NIH has referred to it as post-COVID syndrome, but diseases haven't, with the words post and syndrome, haven't really fared particularly well in our recent medical history. The rest of the world is using long COVID, including the World Health Organization. We've been using long-term COVID because it sounds a little bit better in American English. LTC-19 has sort of a catchy kick to it. What do you think it should be named, and can we settle on a name?
I can tell you something. We're not going to settle on a name right now. That's
okay. Can we start the process then?
Yeah, I think the long-term COVID is certainly better than long COVID. It doesn't even make English right. Long COVID. I didn't like long haulers. That was one of the names. That almost looks like a truck driver who's out on the long hauling a truck. So I didn't like that. But I think long-term is better than long. But we're going to have a workshop in December. We could ask some of the investigators who are out there what their opinion is. But you're right. It's important to have an appropriate name so that it's taken seriously as an entity, as opposed to people not even know what to call it.
Right. I mean, even the media is having trouble knowing how to refer to it. So it's hard to write stories about things that that has no agreed upon name. And many of our members are having tremendous difficulty with their insurance because it's billed under a different name each time. And so there's a lot of paperwork and unpaid medical bills because of it. So I think that it would help a lot of people if we could fast track that. So the next question, of course, the most common question we received, and I don't know that this is one that you're going to be able to answer because we're not there yet, but as the vaccine is developed, has it been taken into consideration how people who have already had COVID might respond, and particularly people who are suffering from long-term COVID?
In other words, if someone is already been infected and then gets
right.
vaccinated.
So I had COVID back in March. When the vaccine comes out, would I be eligible to take it again, take that vaccine?
Definitely. Because we don't know how long the durability of the immunity is following infection. Generally, and I would say, first of all, we don't know. But having said that, if you look historically at how long immunity to coronaviruses last, there are 4 coronaviruses that are responsible for 15 to 30% of all the common colds that you and I have likely had multiple times throughout our lives, which means that the immunity to coronaviruses, at least the common cold coronaviruses, is not very prolonged. It's not like measles. If you get infected with measles, you're protected for the rest of your life. That doesn't seem to be the case with coronaviruses. So there's no reason at all to feel that people who have been infected and have recovered should not receive the vaccine. But I think the point you're making if the virus itself induced this strange kind of syndrome in you, would it be somewhat dangerous to get vaccinated? And the answer is there's no indication that that's the case. We have a considerable number of people, relatively speaking, in the vaccine trials that are going on right now that have come in with antibody positivity for SARS coronavirus 2, which means they were infected. So we're going to be able to determine if there's any adverse effects in those. So those studies are actually already ongoing.
So speaking of reinfection, let's just take me as an example. I had COVID back in March. It's been 7.5 months. So I still have antibodies, but I'm down to a pretty low titer. I'm down to 160. So it's still there, but it's definitely waned over time. I know that that's not an indicator of immunity, of long-term immunity, and that's probably in the T cells. Is that correct?
Right.
But how would I know if I were to be reinfected and be asymptomatic? I could be a spreader. I mean, of course, I'm wearing a mask and social distancing, but how do I know at what point I need to go get tested again if I've been exposed, et cetera?
What you should do is follow the guidelines just as if you had never been infected. Exactly the same thing. If you get exposed, you get tested, you keep yourself quarantined for 14 days. If you get a negative multiple times in a row, you could come out of quarantine. Wear a mask if you think you've been exposed so you don't expose others. You should consider yourself just like everybody else with regard to a second infection.
Okay. I think as far as masks and social distancing, you're preaching to the choir with this group. Most people in this group probably have antibodies, and they're probably the safest people in the world when it comes to taking precautions, because once you've been touched by this virus, you wouldn't wish it upon your worst enemy, and
Right.
you would do anything to avoid getting it again. What do you think the role of T cell testing will be in terms of being able to figure out who might have been originally infected with COVID, and weren't able to get tested at the time?
Yeah, I don't think T cells are going to play a major role in the testing phenomenon. From an experimental standpoint, if you want to see whether T cells, how durable they are, and whether or not there's any correlation between lack of reinfection and T cells. But I do not think at all that it's going to be part of the routine testing at all. It's just a little bit more difficult, a little bit more cumbersome than doing antibody tests. And by the way, even if your antibody titer goes down to a very low level, you still have memory B cells around that if you get re-exposed, your antibody response could then boost up pretty quickly because it has memory. I think people are getting the false impression that if your antibody titer starts to drift down, that you're really losing protection. It doesn't necessarily mean that that's the case.
Thank you for clearing that up. There were a number of articles in the last couple of days suggesting that this waning of antibodies meant that it was indicative of immunity. But do we in general, I mean, this is a basic high school science question that I don't need to be asking the world's leading expert, but I had the chicken pox. Do I still have those antibodies in my body, or is that immunity in my memory cells?
You likely have low titers, 1 to 20, 1 to 40 against that. But you probably have a good number of memory B cells so that if you get exposed again, those cells will start churning out antibody pretty quickly.
Okay, got it. So on a practical level, I have two kids, 12 and 14. If you had a school-aged child, now I know your daughters are a bit older, but if you had a school-aged child right now, would you send them to school right now? And more importantly, because it is tomorrow is Halloween, would you let them trick or treat? And I have a broader question after those sort of yes or no's. Are you concerned about the long-term effects on children's bodies? Both of my children had COVID. I don't know. It worries me when I hear stories of asymptomatic people who are developing, who now are having heart scarring, 6 months later. should we, are we being too cavalier about letting our children get infected without really understanding what the long-term consequences might be for them?
I think that's an important point. There doesn't seem to be any indication, although we are still in that minimal data zone. So I get very uncomfortable about making anything that even resembles a definitive statement when you don't have data. You would imagine that children who are almost always without symptoms are going to have any long-term effects of the virus in their body. But you don't know that as an absolute fact, which is the reason why we have started a study of thousands of families of children who are infected to find out if, in fact, there's any long-term effects, at least that you could measure over a period of 2 to 3 years. So you're asking me questions. I would not be comfortable. As I always joke around when people ask me, I don't want to be the Grinch that steals Halloween and the Grinch that steals.
Okay, I'll do it. I'll do it for you.
That steals Thanksgiving. But I would really be careful about having kids just going from house to house, unless as part of their costume, they had a mask and you made sure that they had a little Purell with them after each house. They would wipe their hands off. You want to do that. I think it could be reasonably safe so long as they don't spend a lot of time interacting with people that they've never seen before. That's one thing. The standpoint of Thanksgiving, I think it's also very important. I'm going to, my 3 daughters who are adult professional women living in different parts of the country, they have decided, because they're worried about their daddy, that they don't want to bring an infection in inadvertently, because they'd have to get on a plane, go to an airport, travel here to Washington, D.C., and only have a couple of days with me. They would rather, even though they really want to see me, they would rather just let it be a pass for this year and concentrate on next year.
I think that makes good sense. Let's all skip holidays 2020 so we can all live to see holidays in 2021. Yep. What should patients be asking their doctors after COVID? Is there any sort of guidance on if you've had symptomatic COVID? Are there certain blood tests that people should be asking for? Are there certain cardiac scans? What kinds of tests should people be looking for? If they're obviously, if you're having a particular issue, you're going to go see a specialist, but there seems to be so many hidden issues here. Or is it just leading people down rabbit holes of medical testing that's unnecessary?
I think the latter. I think what we need to do, which is the reason why it's so imperative for us to do the studies that I'm talking about, the cohort studies of getting enough people in to see if there are any common denominator laboratory tests that could guide you one way or the other. So I think if you start running around from doctor to doctor, you're going to drive yourself to be literally more anxious than you need to be. And there's enough anxiety associated with this rather than trying to compound it.
I think that I would love to go back to what we talked about in the beginning of sort of what kind of therapeutics are in the hopper, both to stave off, things that could be given in the beginning of the disease to stave off the worst effects, and therapeutics for people who've already suffered the ravages of the virus to their various organ systems. You've spoken extensively about monoclonal antibodies, but it seems that the production of them is going to, the difficulty in production is going to keep it from being produced in mass scale. How early would monoclonal antibodies be able to be given? I've heard that you speak about them being given on an outpatient basis or even prophylactically, possibly. Who would they be given to and how early?
Well, we did a study that showed that monoclonal antibodies, when given later in the course of disease after a person's been hospitalized, had no benefit. So since monoclonal antibodies are directed specifically at the virus, you have a window early in the course of disease where the virus starts doing whatever deleterious effect is going to have. The people who have advanced disease that are in the hospital, who are in intensive care, who might require intubation and mechanical ventilation, generally have a runaway inflammatory response. Namely, they have an aberrant, inappropriate, hyper-inflammatory response. For that reason, those drugs that blunt inflammation have shown to be the most successful for those people, which is the reason why a randomized placebo-controlled trial using dexamethasone, which is a potent anti-inflammatory agent, as opposed to a placebo, had a significant effect on diminishing the mortality associated with COVID-19. However, if you look at that part of the disease that would benefit mostly from an antiviral effect, you're talking about a person who may have gotten, like yourself, when you started getting symptoms, within a couple of days of symptoms, if you had gotten a monoclonal antibody, it would have been much more beneficial than if you waited until you really started feeling very poorly.
So that is really, I mean, that's the holy grail then of being able to get a therapeutic to somebody upon diagnosis, as opposed to waiting until they get to the hospital. And so in that same vein, where do immunomodulators and anticoagulants play?
Later, that's later in the course of the disease, because the anticoagulants are against what we call these microthrombi, occur either in small vessels or thromboembolic phenomenon in larger vessels. So you wouldn't want to do an anticoagulant until you have advanced disease and almost certainly are in the hospital. The same for immune modulators. Immune modulators are a fancy way to block inflammation. That's what dexamethasone does very well. There are a number of studies on a number of other immune modulators to see if you could more selectively block those inflammatory mechanisms that are causing the disease, because dexamethasone has a number of other effects that you might want to avoid.
So, I mean, I was thinking specifically about interferons and cytokine inhibitors.
Those are all late. Those are all late.
All late.
Yeah, all late.
So even if, one of the things that we looked at in our 4,000 person study was to look at what medications people were on when they got sick, and how it impacted the severity of their disease. And we've heard a lot of people taking aspirin through their acute COVID to prevent the clotting issues that have become such an issue. Is that something that you would recommend? I mean, obviously, we're not giving medical advice to individuals across the country right now, but is that something that people should ask their doctors about?
Well, you should certainly consult your doctor rather than, as you said, it's not a good idea over Zoom to give medical advice. But it would be unlikely if someone had really early disease with no indication whatsoever at that point that there's any coagulation issues to take anything. I mean, you could take an aspirin if you want, if you have a fever or if you have aches and pains. It certainly has a degree of platelet inhibition, which is something that people use to ward off heart attacks.
It's an antiplatelet, is that correct?
Yeah, exactly. It's an antiplatelet.
I'm learning.
You're good. Keep it up.
Tell my 10th grade biology teacher that. So, I mean, I don't want to go over our time with you. I'm curious, do you have any sort of historical analysis that you could, suggest? Is there a parallel of a situation that we have gone through that has caused so much human misery that we can get some sort of inspiration out of some sort of silver lining? Is there anything that we are learning from this? Science is moving at a faster pace. Everyone has become an armchair epidemiologist. What kind of hope can you offer people?
Well, I mean, the hope is that this will end. It will. I mean, pandemic outbreaks end. They end naturally and they get helped to end with a vaccine. I feel cautiously optimistic that we will have one or more vaccines by early next year that are going to have a major impact on really diminishing the dynamics of this global pandemic. So I believe that we will ultimately, it's not going to be immediately, but we will get back to some degree of normality within a year. And I've been saying by the end of 2021. So that's for the dynamics of the outbreak. But what you're asking is, what about the millions of people who've been infected? That's the reason why we're enthusiastic about doing survivor studies, to find out just what is going on there. What is the extent of it? What is the pathogenesis of it? And is there anything you can do about it?
Well, we at Survivor Corps, Dr. Fauci, would love to partner with the NIH because we have the real-time experiences of all of these people going back to March 24th. So we are sitting on probably the greatest treasure trove of data on non-hospitalized COVID patients in the world. And we would love to work with you and share all of that so it can be used to everybody's benefit.
Right.
So thank you so much. I cannot ignore the fact that we are 4 days away from the most consequential election of our lives. I know that you have spent a lifetime of bipartisanship, but can we agree to vote for science and vote for healthcare policies?
I think we should agree to vote.
Okay, I'll meet you there. I say let's go and vote, get your flu shot and
Right.
vote,
Get your flu
correct?
shot and vote. Exactly.
Perfect.
Good.
I'll agree with you on that one.
Okay.
Thank you so much, Dr. Fauci. This was a tremendous honor to have you on today. And we look forward to working with you and the NIH in the future.
Yeah, thank you. I do look forward to that too. You should keep in touch with us and we'd be happy to work with you. Thank you.
Thank you.
Thank you for having me.